The patient is a 63-year-old pensioner who is a family friend. He is allergic to penicillin, otherwise has a clear medical history. He has had a smile design bridge done at a so-called well-known cosmetic dentistry center over 4 years ago, but unfortunately is unhappy with the outcome. His chief concern was that his bridge that was cemented multiple times kept on dropping out despite many adjustments by the principal dentist over there. He would also like to seek a second opinion with regards to increasing his efficiency in chewing foods. The patient is a very patient man by nature, and he has expressed interest in implants, which ironically has not been suggested at the previous cosmetic dental practice over there. Examination reveals a patient who has a class 1 skeletal profile, normal facial thirds, and adequate symmetry. There's no clicking or abnormalities detected at the temporomandibular joint on palpation, and the patient speaks with a mild lisp with his current bridge. Previously, he was wearing an acrylic removable partial denture, replacing missing 1 and 2 The patient has a low smile line. He has very good oral hygiene with a BPE score of 1. And on intraoral examination, there was an 8-unit bridge from 1/4 to 2/4 that was fabricated, replacing a missing 1 and 2 Elective endodontics was carried out on teeth 1-3, 1-2, and 2-3. The patient reported that the dentist had to do this in order to bring the teeth back in. Metal posts on the corresponding teeth 1-3, 1-2, and 2-3 were placed. On inspection and pulp vitality tests shows that the 1-2 and 2-4 were non-vital. Possibly devitalization has occurred sometime after the bridge work was done. The patient has also impacted 8s and unerupted impacted 4-5. His 4-7 is crown and root treated but shows signs of root fracture, where mobility, buccal draining sinuses, and pain on biting was present. The 4-6 is mesially tilted with heavy amalgam restorations, and his 3-5, which was root treated, had a subgingival fracture and was deemed unrestorable. His 2-6 and his 2-7 were also over erupted, where the opposing teeth 3-6 and 3-7 are no longer there. Other missing teeth includes missing 1-6 and missing 4-4. There is a lack of posterior support, and the patient had to rely on biting with his front teeth. On the bridge, there's sheared ceramics with metal exposure on the palatal sides of the 1-4 and 2-4, which are still considered high, and deflective contacts were detected on lateral excursion. There is a mild tooth wear on incisal edges and crowding, but the patient is not too concerned about aesthetics. The diagnosis shows an occlusal discrepancy with lack of posterior support, and I would deem this as partial edentulosum. The anterior 8-unit bridge is failing with ill-fitting margins and deflective contacts on the premolar region. There's also caries detected on the abutment teeth of the bridge. Root fracture of the 4-7 is also present, and in general, the patient has crowding and impaction of teeth, which, if definitive and comprehensive management, requires multidisciplinary dentistry. Discussion of treatment options are listed in the handout, where no treatment, a new 8-unit bridge, new upper and lower removable partial dentures, or just dental implant therapy alone were deemed as treatment options. However, the definitive comprehensive treatment plan will include a full mouth rehabilitation aiming for a mutually protected occlusion where the patient would have stable anterior guidance and posterior disclusion on lateral excursive movements, where in maximum intercuspation, centric contacts with light anterior contacts are present. The definitive comprehensive treatment plan is basically been divided into 2 stages, in the first stage and the second stage. The first stage would involve stabilization and removal of underlying disease. The endodontic treatment was performed on the Yr4 and Yr4 and has been referred to an endodontist for the management. The extraction of the Yr4 and Yr5 were also done, and the surgical extraction of the Yr4 was performed by a referred oral maxillofacial surgeon. This was because the tooth was very intimate to the mental foramen, and after the procedure, the patient did report of a 1-month paresthesia on their right lip, but fortunately has gained back full sensation after 1 month. During this stabilization stage, supportive periodontal therapy and oral hygiene instructions were given. At the second stage, we aim for the stabilization of occlusion with fixed prosthodontics and implant therapy with a newly designed custom incisal guidance platform where all restored teeth and crowns are to be individualized. A face bowl transfer was taken and occlusion is studied in a semi-adjustable articulator with new occlusal anatomy waxed up. The deprogramming of the temporomandibular joint was also done to train the jaw, the condyles to go back into centric relation, and this was done by a makeshift Lucia jig, where old composite resins were cured onto the palatal surfaces of the old bridge and left there for a few days. After that, the centric relation reading was more easily achievable. A new provisional resin bridge has been issued. This was made by duplicating the palatal anatomy from the wax-up and articulated model. Direct restorations on worn and carious teeth were also done, in particular on the lower anterior incisal edges. The anterior guidance and the envelope of function of the patient is continuously monitored throughout the provisionalization stage. During that time, adjunctive orthodontic treatment was used to straighten and align teeth, namely the Yr4. This was managed by the referred orthodontist. Stage implant therapy involving 8 implants to replace teeth 16, 11, 21, 35, 36, 37, 47, and 45 were planned. Crown lengthening was also performed simultaneously during implantation of the 11 and 21 to provide minimum 2 millimeters of ferrule for the upper anterior abutment teeth for the future definitive crowns. We decided to leave the metal posts untouched as they are mechanically sound, and the attempt of removing them and replacing them with fiber posts may be more disastrous and may risk root fractures. Caries control with caries removal and restorations with resin-modified glass ionomer cement was made. Primary stability of implants in sites 1-1 and 2-1 was challenging to obtain, and the placement were more anatomically driven than prosthetically driven. The sites of bony deficiency were grafted then. The 3-6 and 3-7 implants, when osseointegrated, have been provisionalized with resin crowns that are slightly on supra-occlusion than anticipated. This serves as a dial appliance to intrude the over-erupted 2-6. And of course, the occlusion is carefully monitored throughout the treatment. The patient wears the provisionals, the anterior bridge and the posterior resin crowns, until all dental implants have been successfully osseointegrated and all endodontic and orthodontic works stabilized and completed. The definitive posterior implant crowns were made of porcelain fused to semi-precious metal, cemented to titanium alloy abutments with temporary cements. They were issued earlier on when centric posterior contacts became stable. Cuspal inclinations were made rather flat due to the patient's preference, and the new anterior guidance created by the provisional resin bridge has minimized the risk of posterior deflective contacts and prevented unnecessarily hazardous lateral forces, which of course previously has resulted in the fracture of the tooth 4-7. After successful orthodontic tilting, the 4-6 amalgam restoration was deemed sound, and indirect restoration was not necessary, but of course that tooth is still being reviewed and monitored in case indirect restorations were needed in the future. New alginates were taken and the custom incisal guidance platform was sent to the technician. A second similar semi-adjustable articulator was loaned to the technician after the impression stage, as the current articulator is also used for other patients requiring prosthodontic rehabilitative works. During the second stage, when implants of 1-1 and 2-1 were recovered, the provisionals at 1-4, 1-3, 2-4, and 2-3 were separated and individualized for ease of flossing and cleaning. Crown preparation and impression stage is then performed with protocols taught in the M-Clean and Fix and Removable Prosthodontic program. Attention was paid on achieving a 6-degree taper and at the margin definitions for intimate fitting of crowns without violating the biologic width. The margins are all prepared equigingival. Impression stage was double cord retraction for abutment teeth with closed tray technique for the implants. A single impression technique was used with light and heavy body addition silicones on fabricated special tray and adhesive. The shade taken was A2 Vita Classic, and bite registration in maximum intercuspation was also taken. The records are then sent to the technician with a thumb drive containing clinical pictures to give more description of how the definitive crowns of the 1-4 to 2-4 are to be made. The provisionals are then cemented back in while waiting for the definitive crowns to be fabricated. Monolithic zirconia crowns are then made with the exact palatal anatomy of prior alginate duplicates taken. The material of choice can withstand up to 1,200 to 1,400 megapascals, and the patient is not too keen on aesthetics of translucency. The zirconia block is opaque and can mask metal posts of the abutment teeth and titanium alloy abutments. During the cementing stage, the try-in is passive, and the ceramic coping for the natural teeth are then treated with silane and dried. The abutment teeth are washed with 2% chlorhexidine and pumice to remove residual temporary cement and improve bond strength of the resin cements. Implant abutments are torqued at 15 newtons according to manufacturer requirements, using red pattern resin for correct angulation, rotation, and orientation. Gutta percha sticks and cavet is used to cover the hex screws for future retrievability. The implant crowns are cemented with non-eugenol temporary cements. The occlusion is checked and has been successfully duplicated. No adjustments have been made on the crowns, but some polishing has been done on the lower anteriors. The patient is very happy with the outcome, with improved pronunciation during speech, and expresses a more freer range of movements when the patient grinds his teeth. Outcome of the case. Take note that the posterior rehabilitative works, in particular implant placement in the posterior region, has commenced before the clinician started the MClinDen program and lacked the adequate knowledge and skills then. The patient was let known about his case being documented as a coursework requirement for the full mouth rehabilitation, and was delighted to volunteer and was willing to prolong the treatment plan until completed definitively. With regards to the implant tooth of 1-1, The abutment selection of implant tooth 11 was of a 3.0 sulcus height and a 7.5 angulation, which was partly due to the fault of the technician for his abutment selection. There is a possibility of redoing the crown and abutment with a new selection of 1.5 millimeters sulcus height and a 7.5 or even possibly a 15-degree abutment, as the prosthetic outcome of the 1-1 appears to be a tad bit too labial. The patient has been informed about this and has agreed to redoing it, although he is not really concerned about the appearance and is very happy with the current outcome. Close review and maintenance is then being carried out monthly, 3 monthly, and then biannually. Okay, smile. Yee. Very good, thanks. Okay, say 55.
55.
Okay, 66.
66.
Okay, okay. So how do you find the teeth and so?
Not too much ass.
Okay, that's good. That's good. Wow, very good. Okay, excellent.